I'm a cardiology registrar at Northern Lincolnshire. I'll be talking to you today on acute exacerbation of COPD, which is a common occurrence, this common presentation in our emergency departments, as well as uh, on the medical take. So I know we have F2s from across West Yorkshire, and you're probably not on respiratory rotation now. It could be you're in the emergency department or you're in acute medicine or even surgery. ENT, any specialty you're going to see patients who have COPD is either as one of their comorbidity or their presentation. So we're going to just make it very simple. I know you had an overload today, so this is the last session. So I'll try to make it succinct and very practical for you. Now, I'm going to use this outline, talk about the introduction, causes of COPD, acute exacerbation of COPD, presentation, clinical features, investigation and management. And hopefully by the time we finish this talk, you're able to recognize an acute exacerbation of COPD and manage it appropriately. First of all, by way of introduction, COPD is a chronic inflammatory airway disease, which is caused by exposure to a chronic inflammation, which is caused by either allergens, smoke inhalation, irritants, which leads to progressive, irreversible airway obstruction and airflow limitation. It's important to know that this airway of obstruction in COPD is progressive and it's usually not reversible. This is different from asthma where you have reversible airway obstruction. Most times it is due to exposure to noxious particles, smoke, or irritants, airway irritants. Now, there are certain population of people who would have congenital deficiencies of such as alpha-1 antitrypsin deficiency, and they would also progress to have COPD. There's an overlap between the different types of COPD. In emphysema, you have alveolar damage, and in chronic bronchitis, it is the upper airway that is damaged, the bronchi. Now, by way of classification, the gold standard classification of COPD, the gold guideline says using the spirometry, we have mild COPD, which is FEV1 greater than or equal to 80%. These patients may have no symptoms at all, or they just have mild symptoms of cough and sputum production. As long as their FEV1 is greater or equal to 80%, they will be mild. Now, the moderate category will be 50 to 79%. Again, they may have no symptoms or some symptoms. As we approach severe COPD, the FEV1 drops drastically to 30 to 49%. And most likely, these people will have symptoms, cough and sputum production, chronic cough, daily cough, and the sputum production could be whitish. It's important to know this because when they have an acute exacerbation, the color of the sputum might just be the indication that there is an infection here or there is an exacerbation. Very severe COPD, the FEV1 is less than 30% of predicted, or less than 50% of predicted plus a respiratory failure, type 1 or type 2 respiratory failure. Now, we're going to focus on the topic of the day, which is acute exacerbation of COPD. For COPD patients, they would normally have long-standing chronic cough, sputum production, and sometimes they will have shortness of breath, usually exertional. Now, if there is increased severity of any of these symptoms beyond the day-to-day variations that they normally have, then it qualifies as an acute exacerbation of COPD. This could be mild, not needing presentation to hospital, or quite severe, needing acute admission into hospital. So once you see worsening cough, sputum production, change in color, like I said earlier, the sputum might change from whitish to greenish or yellowish, then you should be considering antibiotics for this patient because they might progress to develop an acute exacerbation of COPD. Now, shortness of breath, most COPD patients will be short of breath. So it depends on how severe, the severity of their shortness of breath and reduced effort tolerance. And that brings us to the dyspnea scale. Now, if you look into their letters in respiratory clinic, which I would encourage you all to do when you have a patient with COPD, they might have graded their level of effort tolerance and shortness of breath. And they use the Medical Research Council dyspnea scale when they are doing this. And if the grade of breathlessness as it worsens, say the person used to be MRC scale 2, who gets short of breath when hurrying on a, say, flight of stairs or walking up a hill, and now he's now too breathless to leave the house. You know that there's a worsening of breathlessness. The day-to-day symptoms are varied, and therefore this patient has an exacerbation of COPD. Now, also, it might just be that patients become more somnolent, less awake, and confused. This might be the first indication that this patient is actually in respiratory failure. So that's another symptom that they may present to you with in ED. Now, acute exacerbation of COPD is a cause of common hospital presentation, and 50% of people with COPD would come into hospital at least once a year with an acute exacerbation of COPD, and there is actually a revolving door crisis in which they come into hospital multiple times with exacerbation of COPD. Now, most of the presentation is infective exacerbation of COPD, and the organisms will be either bacterial infection of respiratory viruses such as influenza, bacteria such as the H. influenza, Streptococcus pneumonia are some of the organisms that are cultured in sputum cultures. Non-infective exacerbation of COPD may be due to continuing smoking, as well as exposure to pollution, or when there is a change in weather conditions. Mostly in the winter, we have more people presenting, coming back to hospital with an exacerbation of COPD. It's important to know the difference between infective exacerbation of COPD, in which patients will present with either respiratory infection, such as fever, with symptoms such as fever, cough, change in sputum production, as against non-infective exacerbation of COPD, in which patients coming with worsening of their dyspnea, cough, without any symptoms suggestive of infection. And the management is usually quite different, mostly the same, but just the fact that they wouldn't have antibiotics if you don't have any raised inflammatory markers or any features suggestive of infection. Now, we will just try to do a case, and I would just need all of you people to join me in this one. So 75-year-old male who was referred by GP with worsening shortness of breath over the last 2 weeks. He has had a fever and a productive cough, and he brought this pot of sputum. He's quite good, so he was trying to help you. So he brought this pot of sputum while he was coming. He's had this change in color from whitish to this dark greenish color. He's got a background of COPD, hypertension, osteoarthritis, and psoriasis. And you went through his medication. He's on first aid inhaler, as well as losartan and amlodipine for his hypertension. He currently smokes 20 pack years, and his functional baseline is quite mobilizes with a stick and is able to walk around quite easily. Initial OBS was provided by the nurse. Temperature is 36.9, SATs was 70%, respiratory rate 23, heart rate of 115, and blood pressure, as we can see. You've examined, and then you saw that he has respiratory distress, and the signs that you saw of respiratory distress were nasal flaring. He was using his accessory muscles of respiration, widespread wheeze on the chest, and crackles on auscultation as well. ECG showed sinus tacking. Now, how would you assess this patient? What if I want to? I will stop my presentation because I want to just read for you. You can drop a message in the chat section so that we are communicating. How would you assess the patient in terms of history? What would you like to know? We have 82 people in the room. So the patient has come in with cough, shortness of breath, and change in color of his sputum to dark greenish. He's also brought in a the nurse has done obs for you, and the saturation is 70%. Is quite breathless and using his accessory muscle of respiration. How would you assess this patient? Yes, thank you very much. The answers are coming through now. ATE assessment is very important because you want to ensure that this patient has an open airway, and you're ensuring that you're suctioning any thick copious secretions that you can see. It might always be that COPD patient are quite thick. If you look at um, that pot of sputum was quite thick and mucky, so it might be that he just needs nebulized saline. You want to listen to the chest too. You've done an ABG. Yes, we have an ABG. So is there any other investigations you would like to request? Yeah. Are you requesting any other investigation? Chest X-ray? Yes. Thank you very much. ECG? Yes. Yes. So thank you. We're warming up now. Yes. So we would request ABG, yeah, ECG. We would want to do routine bloods. And the routine bloods we want, including full blood count, CRP. You want to ensure that the inflammatory markers are raised or not. We need to be paying particular attention to other white cell differentials as well, including neutrophils, lymphocytes. Neutrophils will be raised most likely in bacterial infection. Lymphocytes is important. It might be raised or even reduced if there's viral infection, and also eosinophils. I think the British Thoracic Society, as we are moving towards making some changes in the management of the patient, if the eosinophil count are significantly raised. We need to do a chest X-ray, and we'll be looking at if there's any evidence of consolidation. And if you don't mind, if you can write also in the chat session, if you know what are the features of COPD that you will see on chest X-ray. You can write that down while we move on. Then a flu swab, think about COVID, think about respiratory viruses. Make sure you do a flu swab because this might come back positive, and sputum culture as well. This is very important because not initially you might want to start the patient on antibiotics, but it's more important to sort of to set a baseline for yourself and then switch the patient's antibiotics based on the sputum cultures. Also, you need to also be looking at the previous culture result because COPD patient tends to have commensals in their lungs that may progress to cause an acute exacerbation of COPD, to cause an infection. So we need to be ensuring that their sputum culture results, previous sputum culture results are reviewed all the time because this might guide your antibiotic treatment. Now you have the initial blood gas. Um, pH is 7.32, PCO2 is PO2 is 15.6, and bicarbonate is 30 millimole per liter. You have a start there of 88%. And this blood gas is done on 15 liters non-rebreathe. So what are we thinking at this point? Again, decompensated type 2 respiratory failure. Okay, that's a good thought. Any other thoughts there? Okay, so we have a Slido. Can you see my screen now?
It's coming on slowly, I guess.
Okay.
I've asked people to put their cameras on to demonstrate engagement because we have 80 plus people and
Yeah.
very less number of responses. So I'm a bit worried about this. So, um, but the screen is blank right now. I mean, in terms of the slide.
Trying to I'll stop it and reshare
You
again,
might reshare.
hopefully.
Yeah.
Can you see anything on the screen? Can we see the screen, please?
It's dark.
Is that, oh,
Yeah.
okay. Just trying to do a Slido. Okay. So another thing we can do is just to put the link on there. Let's see. No.
Yeah, you could do that. Yeah.
Okay, I have the link there.
Great. Thanks. I'm sure people will make use of that straight away. Okay.
Can we see the screen now?
I'm sorry, unless other people can see something different, please shout out or type.
Yeah.
I, I can
So
just see
based
a black
based
screen.
on the individual results, they are already giving us answers. So I was hoping that we can see the interaction on the screen. Um, okay. So most people, A says commence non-invasive ventilation, B reduce oxygen, three increase oxygen, and C, D stop oxygen, do nothing. And 79% of people would um, commence NIV. Okay. Okay. Can we see my screen now?
Yes.
Yes.
Okay. So um, most people will commence the patient on NIV. Now we're going to go back to that slide. This patient is on 15 liters non-rebreathe, and pH is 7.32. The patient is hypercapnic and over-oxygenated with PO2 of 15.6. And we have rightly said this is decompensated type 2 respiratory failure. Um, but the initial management for decompensated type 2 respiratory failure would be, in this case, what do we think is triggering the type 2 respiratory failure? Yes, we know that he has infective exacerbation of COPD, but this patient is a chronic retainer from what we can see, and they have put him on 15 liters non-rebreathe and PO2 is 15.6. Will that change what you will do? Can I be a bit Yasmin? I can see you looking at me. So if you don't mind, would that change your management? What would you do?
Yeah, I was just typing in the chat box, target
Okay.
88 to 92%.
Yeah. So you change the target. Yeah. What would be your target? 88 to 92%. That's
Yeah.
very good. And if the patient was already put on 15 liters, what would you do to achieve that target? Tio? Tio Hill, I can see you.
Yeah, that's fine. So as in like if they're on too much oxygen, you can reduce it.
Exactly. You need to reduce the oxygen. So the reason I put in this slide is just a learning point for us. For patients with decompensated type 2 respiratory failure, COPD patients who are chronic retainers, it's important for us not to over oxygenate them. It might actually be detrimental, might be doing more harm to the patient by over oxygenating them. I've lost count of the number of times that we have patients who have COPD coming via ambulance, put in resus, or there's somebody whacks some 15 liters non-rebreathe, and by the time you do the gas, they are in decompensated type 2 respiratory failure, sometimes drowsy and progressing. So it's very important to consider the oxygen at target saturations for the patient. So yes, rightly, we would reduce the oxygen to target 88 to 92 for this patient. Now, in managing patients with COPD, one of the most important exacerbation of COPD is giving them controlled oxygen. And your target is 88 to 92, but also you need to ensure that they are getting nebulizers, short-acting beta agonists with salbutamol, as well as ipratropium bromide. I'm sure we know the right doses, but salbutamol 2.5 is what we'll normally give, and ipratropium 500 microgram. And sometimes, because they have very thick, copious secretions, you give them nebulized salbutamol to try and break down those secretions and clear their airway. They will need to be on steroids, orally or IV. And we should know that this should be short course rather than long course. Obviously, it's also very important to ask the patient while taking your history, how frequently have they gotten an exhibition, and how frequently have they been on steroids, because that will determine what you will do, if you're going to stop the steroid hard stop or you're going to slowly wean the steroids, and give them IV antibiotics. And we've learned in this teaching that either when it is non-infective exacerbation of COPD, you don't want to give antibiotics. The inflammatory markers are normal. The patient doesn't have any fever or any signs of infection. There is nothing on the chest X-ray to suggest infection. You wouldn't give antibiotics. However, in patients who have infective exacerbation of COPD with evidence of fever, evidence of change in color of their sputum, or a consolidation on their chest X-ray, or even if it's a viral infection, obviously that's a different thing. But with evidence of pneumonia, you want to give them antibiotics, and this should be based on local trust guidelines. Or if you look at their previous history and their previous microscopic culture, you want to give them antibiotics based on sensitivities there. Now, obviously, you will consider NIV if the patient is, and we'll talk about NIV shortly. Other things you need to consider is smoking cessation advice for the patient, and that's why it will be important for you to ask for their smoking history. They're still a current smoker in their current smoker at present, and how much they're smoking, because that is one of the single most important intervention that you can do to prevent progression of their disease, but also to prevent recurrent exacerbations. Now, in terms of the oxygen, when treating patients with COPD, we recommend controlled oxygen, and that's why we have the Venturi max, which helps deliver certain amount of oxygen, fraction of oxygen that we want, that we need for the patient to have, and that way we prevent them from being over oxygenated. And these are color coded, from the blue, which is 24%, to the green, that is 60%. And the percentage oxygen are usually written on it. So you just need to look at it. And the respiratory nurses are quite good. They will support you. If you ask them, they will support you in terms of what particular Venturi mask you should be using. What I normally do is, based on the saturations of the patient, I want to say, if the patient is desaturating, say 85% on room air, you could start from 24% Venturi and then titrate up as required to be achieving that target that you want, which is 88 to 92. Now, when you went to see this patient as a very, very good F2, the patient is becoming more drowsy, and you decided to repeat the arterial blood gas after 1 hour. And this is what you get. Again, what have we seen? What is going on here? If you can drop in the chat, I'll be looking. NIV. NIV. Thank you very much. Thank you. Yeah. So now this patient has been on controlled oxygen. You've given the nebulizers, you've given the steroids, and this patient is still sort of getting into worsening respiratory failure, and the patient is even quite drowsy now. So you need to now consider escalation, and this is usually to NIV, which is bi-level positive airway pressure. That's what you need. Before moving to positive airway pressure, I think things that you need to think about is you need to think about this patient is in respiratory acidosis, and you need to confirm that. Now, you need to review the chest X-ray, and it's important to do this because you want to rule out pneumothorax. If the patient has not had a recent chest X-ray, then you should be ordering one. It's important to clarify the escalation plan here, because if you start, what if the patient is not for NIV? Yeah, you don't just jump to NIV. So you need to clarify the escalation plan. I'll encourage you, if you recognize that this patient is in worsening type 2 respiratory failure and is likely to need NIV, you should be talking to your registrars and just trying to, and family, and clarifying the escalation plan. Now, once you've started NIV, we normally start at a lower pressure, and just for it, we start at about 12 to 4 or 12 and 5, and then immediately escalates quite rapidly within the first hour. It is very important to monitor patients with patients with exacerbation of COPD. COPD patients are not the patients that you just do a prescription for and then walk off. I know you have thousands of jobs and you want to get to them, but you can see from starting the oxygen in the first instance and given the first treatment, we have done an hour gas, and that has showed worsening. So if you have prescribed medications for this patient and walked off and not come back to reassess, you're going to have a patient who will deteriorate rapidly on the ward. So it's important, once you start treatment for COPD, monitoring is very important for patients with exacerbation of COPD. And similarly, when you get to NIV and you start patients on NIV, you escalate the pressures rapidly to 18 to 20, and when they stabilize on that pressure, you need to reassess them with a repeat gas at 1 hour after that. Now, what if after 1 hour your acidosis is not improving? What would you do? What do you think will be the next step? Yeah, I'm reading the chat session. What would you do? Say after 1 hour, the patient is on 18.5, IPAP, EPAP 18.5, and the patient is not improving. Yeah, I think you can increase the pressures. Yeah, when you increase the pressures, you also have to reassess again with an ABG to see if there's an improvement. But if despite increasing pressure, you're not getting anything, you're not getting an improvement, then you need to now start thinking, again, going back to your escalation plan. This patient, if the patient is for full escalation, they need to be heading towards intubation and ventilation, and you need to get in the ITU team to come and see this patient. If the patient is, however, not for maybe the ceiling of care is NIV, then you carry on with the NIV, escalating pressures, hoping that you will get results. If not, then it will be towards end of life palliative care if they are not improving on escalating pressures of NIV. Yeah. So now this patient has had NIV and is improving. They are back to the ward. You need to, what they do is that there's usually a local protocol. The patient is improving, you've treated the infection, the respiratory failure, you've repeated the gas, the respiratory failure is improving. The NIV is usually done for 24 to 72 hours as a bridge to rest the muscles of respiration to allow the infection to be treated. And then once the patient improves, you want to wean them slowly off the NIV. And in weaning them slowly off the NIV, it's usually via the local protocol of the department, that Mytt the respiratory department, and they usually just give them breaks. Couple of breaks, say longer breaks from 2 hours to 4 hours to 6 hours from the NIV, and gradually slowly wean them off NIV onto room air. Now, other considerations for patients with exacerbation of COPD, it's important to have a multidisciplinary approach to managing them. And I would recommend getting the respiratory nurses to review their inhaler technique, very useful. They will normally try to get them to see how they are delivering their inhalers, and considerations will be to put in an aero chamber, which normally delivers aerosolized aerosolized component to the lungs directly, increasing the amount of the inhalers that is delivered to the lungs. So improve inhaler technique. Smoking cessation advice is very, very important, and we should be putting them on nicotine replacement therapy while they're acutely in hospital and on discharge, ensuring that they comply with smoking cessation advice. Obviously, if the patients, we should be giving them that advice, and it depends on the patient to take them. Some of them are usually quite quite adamant that they want to continue smoking. In that case, there's nothing you can do. But for us as doctors, we have to always give them smoking cessation advice. MDT approach to management, the respiratory physiologists are quite good with helping with pulmonary rehabilitation, and that usually improves the muscles and strengths of the sort of respiratory muscles and strength, and improves sort of their symptoms and day-to-day life in terms of breathlessness. Follow-up with COPD nurses with the respiratory team should be considered. After an exacerbation of COPD, they might also need follow-up chest X-ray. So if you take nothing from this short talk today, I would say make sure that you remember that every patient that comes in with an exacerbation of COPD, you need to look at their gas and ensure and understand if they are a chronic retainer. If they are a chronic retainer, you need to give them controlled oxygen therapy to prevent worsening or to prevent them from going into decompensated respiratory failure. Now, always reassess the patients after the initial treatment, whether you just give them nebulized salbutamol, which will be the initial treatment and oxygen, or after you have started NIV, just make sure that you reassess them with an ABG, reassess their clinical condition, examine them. And if you see that they are worsening, you then need to think about the escalation plan and what next you want to do. Smoking cessation is very important, and at every point in time when they come across a clinician, you need to be reinforcing smoking cessation advice and offering smoking nicotine replacement therapy. And make use of the MDT, the nurses, the respiratory rehab, the nutritionist. They are quite helpful, and they cover other aspects of care that will improve patient outcomes.